Good evening, everybody. Thank you, Dr. Amel. I would like to thank you for your kind invitation to this conference. I would like to thank the chairpersons and thank the audience for their patience. So today I'll be talking about a case with thrombocytopenia. And the main message is not every case of thrombocytopenia is a patient with ITP. So I'll be talking today about this 3-year-old boy who presented with a post-traumatic raccoon eye and scattered ecchymotic patches all over his body. There was no bleeding from any other orifices. He was well grown with the weight on the 50th centile for age and height between the 25th and 50th centile. By examination, there was petechiae and ecchymosis all over his body and no palpable organomegaly. So we did our routine investigations, which revealed mild anemia with hemoglobin 10.8 and severe thrombocytopenia with platelets 38. So we've done a bone marrow aspirate that showed relatively depressed myeloid series, marked erythroid hyperplasia, and defective lobulation, granulation, and platelet budding in the megakaryocyte series. There was no abnormal cells. At this point, it was anticipated as a case of ITP, and treatment was started in the form of steroids at a dose of 2 milligrams per kg per day. And actually, there was an improvement in the platelet count, which rose to 255. However, 2 weeks later, with stopping the steroids, the platelet count dropped to 51. And 2 months later, the patient presented with acute pallor jaundice dark urine, which was preceded by upper respiratory tract infection, not preceded by diarrhea, and not related to meal intake. By examination this time, the patient was pale, was jaundiced. There were purpuric eruptions all over the face and no palpable organomegaly. Laboratory investigations revealed bicytopenia. Hemoglobin was 5.2, platelets was 7, elevated retics count was 7.1%, total bilirubin was 6.3, it was mainly indirect, and D-dimers were high. At this point, the patient was managed as a case of Evans syndrome, and he was pulsed methylprednisone at 30 milligrams per kg per day for 3 days. The past history of this patient is significant of open heart surgery for a large ASD closure at the age of 2 years, during which he received blood and platelets during recovery. Taking a closer look at the family history, our patient is the 5th child of a consanguineous marriage with a similar condition in his sister. So what's wrong with his sister? His sister is now 6 years old, but when she was 3 years old, she presented with bruises and ecchymotic patches all over the body. She was again well grown with a weight between the 50th and 75th centile and a height between 25th and 50th centile. She presented mainly with the dilated veins all over the face and abdomen, and at that time she had a palpable splenomegaly. Sister's investigations revealed again a bicytopenia, hemoglobin 7.6 and platelets were 10, schistocytes 0.6%, elevated reticulocytic count 3.6%, consumed haptoglobin, and a high D-dimer. Bone marrow aspirate for the sister revealed normal morphology and maturation of the myeloid series. The erythroid series showed hyperplasia with megaloblastoid changes. Megakaryocytes were increased in number with normal lobulation. She was treated as a case of chronic DIC and received blood and platelets. She was started on steroids with no improvement of the condition, and she was on regular bi-weekly platelet transfusions. With this history in mind, we had to revise the diagnosis for our patient, and we came up with a diagnosis and started working towards it. So we repeated some of our labs, and the blood film came back positive for schistocytes. Coombs test was negative. Again, there was anemia, thrombocytopenia, high retics count, and total bilirubin 6.7 with a mainly indirect and a high D-dimer. We changed our diagnosis, and we started giving our patient twice daily plasma transfusions and gradual tapering of the steroids. 2 weeks later, our patient count improved with hemoglobin rose to 10.2, platelets 117, few schistocytes on the blood smear, Retix was 0.3%, and the bilirubin dropped and the D-dimer dropped as well. And we received the results of the ADAM TS13, which came back less than 10%, 3.2, and the ADAM TS13 antibodies were positive. And we diagnosed our patient as thrombotic thrombocytopenic purpura. We came back to his sister and we did ADAM TS13 for her, and it was consumed as well, 27%. She received plasma transfusion once daily and her platelet count rose to 95. Thank you.